Hello, everyone. So my clock says it's 10 o'clock on the dot, and I think we can get started. We have pretty great attendance today. I'm very excited. Thank you all for coming. Today's webinar is sponsored by the Northwest ATTC and the Western States node of the NIDA Clinical Trials Network. My name is Meg Bruner, and I'm hosting today's event on behalf of the NWATTC. Before we get started, just a few housekeeping things. If you have any questions for Dr. Korthuis, feel free to type them into the chat box at any time during the webinar, and then we'll have a Q&A at the end. This webinar is being recorded, and the recording and the slides will be made available on the NWATTC website later today. I'll also be sending you all an email later today with a link to a survey and also a link to our website where you can find the slides and the recording. And then in a few days, I'm not sure how long this usually takes, you'll also get an email from us with instructions on how to get your certificate for your NADAC CEU if you stay for the full webinar today. Okay, so let's get started. Today's speaker is Dr. Todd Korthuis, who is a professor of medicine and public health at Oregon Health and Science University, where he serves as Chief of Addiction Medicine and Program Director for the OHSU Addiction Medicine Fellowship. His main research focus is on integrating addiction treatments into diverse healthcare settings. Dr. Korthuis also serves as co-principal investigator of the Western States node of the CTN and has led several NIH studies of buprenorphine and extended-release naltrexone integration in HIV primary care settings. We're very fortunate to have him here today to talk to us about buprenorphine for the treatment of opioid use disorders. So welcome, Dr. Korthuis.
All right, thank you so much, everyone, for taking the time to join and talk about this important subject. I'll just go ahead and advance here. Okay.
You may need to click on the slide in order to advance it. There you go.
There we go. Okay. Yep. All right. So our objectives today are, first of all, to understand the biological basis of medications to treat opioid use disorder, and specifically buprenorphine, to review recent data on the effects of buprenorphine on patient outcomes, and introduce tools for integrating buprenorphine treatment into your current treatment setting. And I've tried to leave this somewhat general. I suspect that many of you are working in specialty treatment programs, and I'll try to speak to that. And I'll also be referring to implementation of office-based buprenorphine. So I think the first thing to just put right out there is that medications are really now the current standard of care for treatment of opioid use disorder. Use of medications like buprenorphine, methadone, and naltrexone to treat opioid use disorder is really best practices now. As a consequence, states are increasingly requiring treatment programs to offer medications for opioid use disorder as a condition for participating in state Medicaid programs or receipt of SAMHSA funding. Despite this, there's still limited uptake of buprenorphine. This data is a few years old now, but the last national assessment showed that about a third of addiction treatment programs nationally offer any sort of medication for the treatment of opioid use disorder. And things are challenging in primary care as well. Only 43% of US counties currently have any waivered, 43% have no waivered buprenorphine prescriber. And many of those who are waivered and able to prescribe buprenorphine are not prescribing buprenorphine. So lots of challenges to support people in adopting this. Some of the barriers to the adoption that were determined in a survey of primary care providers demonstrated a lack of belief in agonist treatment as one important barrier. Lack of time for new patients. These are very, very busy providers with lots on their plate, and the thought of adding one more thing can be a barrier. And the belief that reimbursement rates are insufficient. So when we think about medications for opioid use disorder, there are essentially three types of medicines. There's methadone, which is a full agonist, buprenorphine, which is a partial agonist, and then naltrexone, which is a complete antagonist of the opioid mu receptor. If we focus on buprenorphine as the partial agonist in this middle diagram, what you see is, in contrast to the full agonist, if you take a little bit more, you get a little more effect. A little bit more, you activate that mu receptor a little farther. But very quickly, actually, no matter how much more buprenorphine you take, you reach a plateau. And fortunately, this plateau occurs below the level of respiratory suppression in a patient who is physically dependent on opioids. And this is in contrast to any full agonist, whether it's methadone or oxycodone or even heroin. That curve, you can take more and more and get more mu opioid receptor saturation and activation until you surpass the level of respiratory suppression. And this is what makes buprenorphine safer in terms of overdose risk than any of the full agonists. We like to prescribe it at least in less controlled settings, in primary care, for example, in the 4-to-1 combination, along with naloxone. The naloxone is inactive if it's just taken as directed under the tongue sublingually. However, if you try to inject it, this precipitates withdrawal, and it's meant to decrease substance use. It comes in both tablets that are now generic and also films, which are still branded. It's given typically once daily, but it is safe for flexible dosing, particularly in patients with chronic pain who get a little better analgesic effect if you split that dose through the day. In terms of what's going on at the receptor, how does it work? This purple is an activated mu receptor in someone who's dependent on opioids. And because the opioid mu receptor is empty, it's sending signals that are communicating pain to the brain and withdrawal symptoms. A full agonist opioid, for example, like methadone, works by completely attaching as a perfect fit to the opioid mu receptor and giving relief to the opioid withdrawal symptoms. In the case of heroin, you're also getting the euphoric effect with that perfect fit binding. Buprenorphine in the small yellow dots works a little differently. It attaches with greater binding affinity, and it's stickier at this opioid mu receptor and actually blocks the other full agonist molecules from attaching to that opioid mu receptor. It does, however, give enough activation at the mu receptor to allow relief of withdrawal symptoms. And finally, the dissociation of buprenorphine from the opioid mu receptor is quite slow, and that's what makes this a 24-36-hour medicine, sometimes even longer, because it's released very slowly and continues to block other opioids on that receptor for some time. How does buprenorphine compare with methadone? This is just one of several studies that was a sentinel study, a randomized trial that randomized people to high-dose methadone that was 60 to 100 milligrams per day, buprenorphine, or low-dose methadone. They assessed both treatment retention and urine drug screens over the course of about 4 months. And what you see here is the high-dose methadone had slightly better retention. This was not statistically significant. However, subsequent studies For example, the START study in the NIDA Clinical Trials Network did demonstrate that statistically significant treatment retention in opioid treatment programs with the high-dose methadone compared with the buprenorphine. But both of those were clearly superior to the low-dose methadone. I'm leaving LAM off of the slide, which was also included in the study and is no longer available. In terms of urine toxicology screens, buprenorphine was almost identical to high-dose methadone in helping people achieve negative urine drug screens by the end of the study. So the take-home point here is buprenorphine and methadone are equally effective in terms of helping people enter recovery. Methadone is probably more effective in OTPs for keeping people in treatment longer. What about detox? You know, clearly what a lot of people would love is any medicine that you take for a few days or a few weeks and can quickly taper off. In other words, detox, and not be on opioids anymore. However, this is not effective. This was the first study, a small trial from Sweden that randomized people to maintenance on buprenorphine versus buprenorphine detox in the green dots. And what you see here is that the percent remaining in treatment quickly went to 0 within the first month of those in the detox arm, whereas those in maintenance had 75% negative urine drug screens and retention and treatment after 1 year. And this was a small study. Despite that, there were no deaths in the maintenance arm, and 20% of those who were randomized to detox died of overdoses in that time. Much more recently in the US, the NIDA Clinical Trials Network POTE study was a multi-site trial of buprenorphine for the treatment of prescription opioid use disorder in 10 primary care clinics around the country. And it had a detox phase followed by a maintenance phase for those who relapsed. Success was determined fairly generously. It was, quote, minimal or no use of urine of opioids by self-report and on urine drug screen. And what you see here is that during the detox phase, only 6.6% achieved success by 12 weeks, whereas those assigned to the maintenance phase, about half were successful, which is comparable to our success rate with other addiction treatments. So the bottom line is, as attractive as detox may be as an idea for a lot of people, it's not a safe option. This is a study that was just published in the last 12 months that everyone should be aware of. It was a meta-analysis of 19 studies of people who entered treatment with buprenorphine. It also looked at methadone, and the story was the same. I'm just showing the buprenorphine results here. In the dark blue bars, the dark blue bars represent people who were out of treatment, whereas the green bars represent people who were in treatment. And what you see is more than doubling of mortality risk in people who are out of treatment compared with those who are on treatment with buprenorphine. And this was true on the left, both for all-cause mortality and on the right for opioid overdose risk, with even a bigger increase in overdose deaths following discontinuation of buprenorphine. So again, the take-home message here is longer is better, and probably continuous maintenance is the way to go for just about everybody. So how do we do this in clinical practice? I'm going to go through several tools. I'm not going to get deep into the nitty-gritty of induction strategies, but I'm happy to field questions on those. I think one of the most helpful things to come out in the last few months was the revised tip on medications for opioid use disorder, tip 63. I would encourage all of you to have this in your practices handy. It's available online. You can also request a free copy directly from SAMHSA by Googling tip 63. It really is a quite comprehensive guide for implementing buprenorphine, but also methadone and naltrexone in your practices, and gives very detailed recommendations of how to do this. One of the first steps in integrating buprenorphine into clinical practice is to focus on the whole team. In office-based buprenorphine treatment, you know, theoretically a single prescriber can do this all on her or his own. But I've found in trying to support practices in adopting buprenorphine that it really works better if you have at least a core team of your staff that are really supportive of this practice. And this includes front desk staff, phone room staff, medical assistants, nurses, other docs in the practice, including nurse practitioners and PAs, a counselor if your practice is lucky enough to have one, and certainly leadership support from the practice medical director and manager. It's very helpful to designate a buprenorphine coordinator for the practice. I call this the glue person. They're the people who just hold it all together and help tremendously with coordination. In my past practices, I've had this be a CADC counselor. I've had it be a social worker, a nurse, and for a couple of years we had an incredibly capable medical assistant who filled this role and helped track the patients over time, called in patients when they were due for follow-up visits and urine toxicology screens, and really just kind of knew the practice and knew who was getting bup and how they were doing. Are all of these roles required? Absolutely not. You can do this as the solo prescriber in rural areas or elsewhere. Don't wait for the ideal situation to start implementing it. Just start, and then gradually, as the number of patients you're taking care of increases, perhaps you can add additional roles. As you are expanding, or even if you're just a solo practitioner, it's really important to build a shared philosophy and scope around what it is we're trying to do. And this is this involves several things, but I've listed a few of them on this list. Really communicating to staff the importance of recognizing and monitoring withdrawal symptoms, instead of just labeling someone who's coming into the lobby and pacing and having potentially disruptive behavior as quote unquote acting out. the staff are coached to recognize that, hey, maybe this is withdrawal symptoms, and the faster we can get this patient roomed, the more or the less disruptive they will be in the lobby, and get them comfortable quickly. The importance of timely buprenorphine refills. We don't want the phone staff saying things like, we'll let the provider know, and then the refill request sitting for 3 days. And if the whoever is answering your phones knows that and managing the refills, they'll be sensitive to this. Another culture change that practices inevitably go through as you start to do this is embracing substance use disorders as medical conditions. Just like diabetes or asthma, substance use disorders are not a moral failing, they're not a character flaw. This is what we do in medicine. We take care of people with medical issues, and this is just another one of them. Another cultural shift that I find helpful is framing urine toxicology screening more as medical safety and a communication facilitator rather than a policing activity. You know, we're trying to catch you, and I try to get away from that and really communicate to the patients and the staff that this is all about giving us tools to more safely take care of the patient and use it as a communication device with the patient in front of you. Hey, what do you think the urine tox showed today? You know, what should we do about it? I know I'm spending a lot of time on this one slide, but this is just crucial for culture change in a lot of settings. Another thing to address head on is the concept of relapse. Let the staff know that relapse is common, but that does not equal failure. And the goal is to limit the duration of relapses, limit the number of relapses, and then build on those periods that hopefully get longer and longer and longer in between periods of relapse that are success. And then talking with the staff about the timing of buprenorphine induction is important, and we'll talk about that in a minute. Who does what? In the office-based buprenorphine treatment setting, the phone desk or a phone staff room person is scheduling and doing really the face of the practice, and that's why this is so important to include them in this conversation. The medical assistant or nurse may be administering the COWS, clinical opioid withdrawal scale, that we'll talk about in a minute, collecting and running point-of-care urine toxicology tests, maybe even doing prescription drug monitoring programs, logging onto your state database. The primary care provider is confirming the DSM-5 diagnosis, assessing comorbid conditions and addressing those as well, and monitoring progress over time. If you have a counselor, the behavioral counselor is providing support for relapse prevention and treatment engagement, as well as perhaps assisting with monitoring for safety. And then the clinic medical director is responsible for ensuring that there's a protocol in place that doesn't rely on a single person, but that applies to the whole clinic. So prior to induction, which is just another way of saying this is when we're going to start buprenorphine, it's helpful to counsel the patient on both alternative treatments of methadone and naltrexone, and the timing of induction, letting them know when to come in, the risk of precipitated withdrawal, and the need for behavioral treatment. And I should add, around behavioral treatment, the role of behavioral treatment is not necessarily to improve abstinence. You know, we have data in several studies now that show that doesn't actually add that much to the abstinence outcome compared with the medication alone. What I encourage people to use behavioral treatment for is addressing all of the many issues that have gone to the back burner while they've been using opioids. And all of a sudden now they're out of withdrawal. They're not using heroin or prescription opioids, but guess what? Their marriage is still there. Their financial issues are still there. Sometimes their legal issues are still there. And all of those things are major potential triggers for relapse that need addressed through behavioral therapy to get them to just a better overall functioning position in life. I like to start with a treatment agreement. There are many online that you can use as templates. Labs are not essential, but we typically will at least collect urine toxicology screening. It's very important to screen this population at least annually for HIV and Hep C, as well as hepatitis B, pregnancy, and liver enzymes at baseline. And then one thing that's important not to forget is in our current funding environment, in most states, it's very helpful to write the prescription for buprenorphine before they come in for their induction. And this is because many state Medicaid programs and managed Medicare programs will require prior authorizations to fill the prescription. And you don't want to find that out when somebody's coming into the office in withdrawal. So I'll typically write, say, a 3-day prescription of my best guess of what I think they'll need and what I want to use for the induction, and have the patient bring that to the office. Of course, if you're in an OTP, this is all very protocolized, and there's no need to write a prescription. When the patient is ready for induction, it's important to schedule this as soon after the intake visit as possible. And the key is they need to be in mild to moderate withdrawal in order to begin induction. The more severe the withdrawal symptoms, the greater the relief. So the longer they can wait, the better. Withdrawal symptoms are typically sufficient after 12 to 24 hours after a last dose of a short-acting opioid like heroin or hydrocodone, and 2 to 4 days after the last dose of a long-acting opioid like methadone, depending on what dose they were on to start with and how long they were taking it. We use the Clinical Opioid Withdrawal Scale, or COWS, to assess the timing of that first dose of buprenorphine. The COWS rates 11 symptoms of withdrawal and comes up with a score. It's typically safe to give the first dose when the COWS is at least greater than 8. I prefer to wait till 12 or more. Again, the more withdrawal they can tolerate beforehand, the more relief they'll get from their first dose of buprenorphine, and the more likely they'll be to come back and continue engaging. For those of you with electronic health records, you can adapt this into your EHR. And so in my practice, the nursing staff simply go through in our Epic electronic health record and quickly check off the responses, and it generates a total COWS score. And then we repeat that every 45 minutes or so, half hour, until they're ready for withdrawal. There are at least 2 treatment phases, somewhat blur together. Induction can last 1 to 3 days. Again, the patient must be in moderate withdrawal. I'll typically start at 4 milligrams and then gradually increase, titrating to effect, with shooting for an average dose in most patients of around 16 milligrams. But there's a wide range around this. And then stabilization and maintenance will continue to occur over the next couple of weeks. We just continue to engage the patient with return visits and random urine toxicology screens and counseling if available. And patients can typically continue for years on buprenorphine. Here's my very rough guide. On day one, we'll start with 2 to 4 milligrams, wait 45 minutes, and redose for typically at least 8 milligrams the first day, sometimes 12 to even 16, and then so on and so forth. The next day, you give the total dose that was required on the first day, plus an additional 4 milligrams if needed. Third day, similar, and then increasing to max dose of 24 milligrams per day maintenance. Okay, so how do you avoid precipitated withdrawal? Again, it's all about the timing. If you're starting with a lot of immune receptors activated up on this higher curve, and you give somebody buprenorphine, you're going to bring them down to that plateau of a partial agonist. Whereas if you start with, say, 10, 20% of your opioid immune receptors activated, and you give somebody buprenorphine, they're going to feel much better, and you're going to bring them up to that plateau level eventually. And they'll keep coming back for more. If you do have a situation with precipitated withdrawal, you essentially have 2 choices. The provider can, first of all, if the patient just isn't having any more of this, treat symptomatically with non-narcotic ancillary medications like clonidine, potentially tizanidine, something for sleep, etc., muscle aches and pains, nausea, and reschedule. I prefer to avoid that. The supportive meds are fine, but if it's at all possible to keep the patient there, it's better to try to push through the withdrawal symptoms, continuing to slowly increase the dose of buprenorphine and overcome the withdrawal symptoms that have been precipitated, reassuring them along the way that they are going to feel better within the next day. It's just going to be a little rocky that first day. And then also, of course, giving them the supportive meds as they're going out the door and checking in with them the next day. Here's a typical rough guide for office-based treatment schedules. Some of this may be pertinent to addiction treatment programs as well if you're using an office-based model rather than an OTP model, which typically rolls out similar to methadone. We already talked about before induction doing the prior authorization and treatment visit, and ideally having an initial clinic visit, counseling them about the benefits and risks and alternatives, and collecting labs, etc. During the induction phase, I like to have the patient come back or at least touch bases by phone twice that week. And I'm only giving a 1 to 3 day supply depending on what their visit cycle is. For that first month after induction, we try to see the patients weekly. They receive counseling weekly, and which may or may not be on site. And again, the counseling can really fall under and be tailored to what you have available in your practice. If you have 12-step groups available in your community, but no counseling, that may be your alternative for counseling, and that's okay for getting started. I only give a 7-day refill and tie those to the clinic visits typically in that first month. If they're doing great after the first month and have had consistently negative urine toxicology screens and keeping appointments, then I'll stretch the visits, the counseling, and the refills out to every 14 days. If they're still doing well after month 2, then in month 3, we'll go to monthly follow-up visits, and then readjust this as people have bumps in the road and periods of relapse. And again, the goal with addressing those relapse periods is to keep them as short as possible and keep a wide open door for that patient to come in and say, I slipped up this weekend, and start where you left off. I also should say that there are very stable patients. I've been doing this since 2004. I have some patients who've now been on buprenorphine for 14 years, and they're rock solid in their recovery, and those patients, I think it's reasonable on a case-by-case basis to stretch out the refills and the clinic visits longer than a month on a case-by-case basis. Okay. I should also talk about the growing phenomenon of home induction. Home induction is not something that was recommended very early after buprenorphine was approved, but this has changed due to some very good research where people are randomized to office-based induction versus sent out for unobserved home inductions. And the results have been equivalent in those two populations. And so the TIP 63 guideline now allows for this and gives some pointers. It's very important to select the right patients for this. And in my experience, the patients who are going to succeed with a home induction are those who understand the induction process, either because you've explained it very carefully with them, or honestly, if they've had prior Bupre experience themselves, either supervised or unsupervised, and had a good experience starting buprenorphine at home. That was actually one of the predictors of success in these clinical trials. So that's a good thing. And then making sure that the patient can contact the provider for problems and maintaining close phone consultation during the induction process. So, for example, I'll see somebody in the office perhaps. I would never, by the way, you'll get phone calls for, hey, can I do a home induction for a patient you've never seen before or one that hasn't come to the office, and obviously those aren't the patients we're talking about. I'll have an initial intake with the visit with the patient, and then write the prescription. We'll come up with a time frame for when they're going to take their first dose. They know to call me if they're having any issues, and then I'll call them usually late morning or early afternoon of the day that they have chosen for their induction, just to make sure everything's going well, and then see them back, usually ideally at the end of that week, that same week, or within a week for certain, to make sure everything's going well. One of the original publications also published a handout that you can find in this reference and online that sort of maps out with these smiley faces and frowny faces how exactly the patient can do this. There are other resources that are similar online, PCSS website and other places. And then I will just end with some thoughts and comments on misuse and diversion. So misuse, first of all, is when a patient is using buprenorphine in a way that was not intended. And sometimes that's trying to melt down the films and sniff it. Sometimes that's chewing the pills, trying to get high with the buprenorphine, or diversion. Diversion is when they're not using it or all of their prescribed medication, and then giving it to others. When this comes to light, I try to stress my willingness to continue working together. It's typically not productive to say, I'm sorry, this is the end of the road. You know, we're not going to see each other again. It's important to the greatest degree possible to maintain that bridge. However, it's really on the clinician to consider a higher level of care, whether or not that's indicated. For example, you may be able to provide a higher level of care in your own office. If this is somebody you've been prescribing in office-based buprenorphine, perhaps the first step is to increase visit frequency and monitoring. A next higher level of care might be referral to dispensary-based buprenorphine or methadone. And that's particularly attractive for those of you working in opiate treatment programs. You know, you have the capacity to, you know, do this with directly observed therapy at a dosing window every day. And for some patients, they'll do better with that approach. And then for patients who are refractory to those interventions, or perhaps have complicated polysubstance use disorder, those are patients who I try and refer for residential treatment. I say, or IOP, intensive outpatient programs. And those are, my conversation there is, you know, it doesn't seem like it's safe for me to continue prescribing like I've been doing in a primary care setting. And I am willing to do that again in the future, but I think to get there, you're going to need one of these other treatment approaches first. And after you've had some success there, let's be sure and touch bases again and talk about plans for the future. Regardless of what higher level of care you choose, make sure that higher level of care is not no care. And I know many of you and many of the people that I speak with are working in communities with very limited access to treatment and very limited options for referral. And in that case, you know, I try to take more of a harm reduction strategy. The one situation where I will completely cut off prescribing is for clear-cut diversion, where the patient is not having a positive urine tox screen for buprenorphine, and they admit, usually to the counselor, not to me, that they're not taking it and they've been selling it or whatever. Obviously, that's an indication for completely stopping prescriptions. But again, making sure that they're safely addressing all of their use disorder or use disorders in other ways. And then finally, there's now the option of considering a switch to long-acting naltrexone, or now extended release buprenorphine injections that'll last a month. So that's another option that we talk about with patients who just aren't flying with the office-based buprenorphine approach. And I want to leave plenty of time for questions and just leave you with a slide of implementation resources. And I'm very excited to say that we've had a dramatic increase in resources for providers who want to do this. There's the USCF Substance Use Consultation Warm Line. I don't know if any of you previously used the HIV Warm Line, but they now offer this specifically for supporting approach to addiction issues. And I have the phone number here and the hours. And they give outstanding expert advice. If they don't know the answer, they'll take your phone number and call you back in a couple of hours after speaking with someone who does know the answer. Really great resource. Then, of course, the provider clinical support system has been around for a while. I have the URL there, and PCSS provides a lot of resources on its website in terms of forms and protocols and paperwork that you can use to implement this in your practice. They also offer a mentoring service where you fill out a very brief application and can sign up to have an expert mentor guide you through that first induction and just bounce questions off of. And then very new this year, there's the State Targeted Response, or STR, Technical Assistance Program, which provides both practice and systems mentoring for treatment centers and practices that want to set up a better system for taking care of opioid use disorder. Many states also offer ECHO programs that provide telementoring, where the provider signs up or joins a webinar essentially once a week. There's usually CME associated with that. They share their difficult cases, have an expert panel discussion for feedback and consultation, and then usually a very brief didactic as well. And then finally, I've listed the full reference for the Tip 63 that was just published in May and available online. Be sure and check out those resources, and let's stop there and take lots of time for discussion and questions. I'm really curious to hear your thoughts.
Great, thank you so much, Dr. Korthuis. So we do have a couple of questions that have come in. The first one is, you mentioned that you had someone on buprenorphine for 14 years, and a person is wondering if there's any research on the impacts of long-term use of medications for opioid use disorder.
That's an excellent question. There is not a lot of research on very long-term effects like this. We can infer that at least for methadone and buprenorphine, they probably are susceptible to the same things that anyone on long-term opioid therapy is susceptible to. Gonadal suppression, for example, and other issues. Buprenorphine tends to have less issues with suppressing the gonadal axis. It has less issues with obstipation and weight gain as well.
Great. Another question is, at what point are patients to begin weaning off of buprenorphine? How long until they can be free from having to take anything?
Oh, that's another excellent question. And the short answer is, I don't encourage people to wean off. I think the best way to frame this as a maintenance is as very long-term maintenance for people, certainly with severe use disorder. I always have patients that want to get off of buprenorphine for many reasons as soon as possible. And what I counsel them in two ways. First of all, when I'm starting buprenorphine, we have a discussion that I want them to commit to 12 months of therapy, no matter what. And the reason for that is all of those back burner issues. You know, it's one thing to get out of withdrawal and to start to have brain healing and dopamine release start to normalize. You know, that can happen over the course of weeks to months. It's a very different thing to address all of those underlying triggers in your life for relapse prevention you know, to start working a job again, to repair those relationships with your family and friends. And that's the work of a lifetime potentially, but in my experience, is tough to pull off in less than a year.
Interesting.
So I encourage them to think about a year going in. And then for patients who really do feel like they want to give it a try without medicines, after that year, if they've been incredibly successful, my criteria for considering a taper in someone is, number one, that they have sustained recovery, both in terms of non-use and in terms of their overall life function. And number two, that they are in an environment that's supportive of recovery. You know, this isn't going to work if they're, you know, living with someone in their house who's currently using, for example, or if they're in that same neighborhood where they have continuous exposure to utilization. And three, that they commit to keeping in touch and letting me know how it's going. You know, and maintain a very open door, talking frankly about relapse and what that means. You know, I stress that, you know, I'm rooting for you. We wouldn't be trying this if you weren't doing really well. But if you have a slip up, come back, and come back after one day, not after 3 months.
That sounds like a really empathetic approach. I really like that. Yeah.
The other thing is anyone who's considering tapering off buprenorphine should be prescribed Naloxone rescue kits.
Mm-hmm. Mm-hmm. Okay, next question. What do you do for patients who continue their stimulant use but have decreased their opioid use?
Oh boy, that is such a thorny question. I can tell this is a very experienced group. Yeah, particularly in the Western United States, but increasingly actually in the Midwest, and to a lesser degree on the East Coast. Methamphetamines are really a major challenge for buprenorphine prescribing. And I think I'm going to give a couple of answers, and they're going to sound different, okay? I think the first point is you as a practice have to decide how you want to handle that. And every practice is going to have a different comfort level. It's okay if you feel that you don't have the resources in your current practice to address ongoing methamphetamine use, and that's a non-starter for you, and that's just somebody you're not going to be able to continue to prescribe buprenorphine to. That's a legitimate approach. Hopefully, if that's your practice's approach, you have recourse and backup to referrals for a higher level of care, so that patient isn't being left without treatment options. The other approach is to take a more harm reduction approach, and in this approach, it depends on really the level of use and how much methamphetamines is affecting their life. You know, I've had patients who will occasionally use methamphetamines at a party, you know, once every 6 months. In that patient, we just have a discussion about, you know, I know these things happen, and I treat it just like I would an opioid relapse. Let's go to weekly visits for a while and talk about this, and you can stretch out those prescriptions when we've had several urine toxicology screens in a row that are negative for methamphetamines. And then I have other patients who have a higher level of use, and I really try not to stop buprenorphine, to be honest, but I try to better address the methamphetamine use. And sometimes that that involves the threat on cutting back on buprenorphine. For example, I'm thinking of a particular patient of mine recently who just, we tried the increased monitoring. He would miss appointments. He was coming in with, at least 50% of his urine toxicology screenings positive for methamphetamines. Over the course of, this went on for 6 weeks. And what we came up with was a plan for a higher level of care where a requirement for me to give him a 7-day prescription of buprenorphine was that he enroll in one of the potential IOPs, intensive outpatient programs in my community, and really engage there and give me a release of information so that I'm talking with that counselor in that treatment program. That's one approach. I've required people to go to residential rehab for methamphetamine use disorder in order for me to consider resuming their buprenorphine prescribing. So anyway, that's my approach, which is clear as mud, I'm sure. But I think you do just have to tailor it to the patient and also to your practice's level of comfort and resources in your community.
Mm-hmm. So one viewer notes that it seems like we have many more people with opioid use disorder than we have buprenorphine prescribers, and they want to know what you think might be a solution to that problem.
Tell your friends. The PCSS website is one that you can access for trainings, for buprenorphine waiver trainings. If you happen to be in the state of Oregon, you can call the OHSU addiction program and we'll set up a bup waiver training for you. I think the biggest thing, though, that's going to convince more providers to prescribe buprenorphine is seeing a patient who is successful. So those of you who are starting to use buprenorphine, talk about your successes. Really, it doesn't take more than 1 or 2 patients who go from being really challenging and a drain on the practice in some ways, to being just this wonderful interactive patient, to convince a whole practice that this is a good thing to do.
Mm-hmm. The next one is, thanks, Dr. Korthuis, for this excellent talk, which I agree, that was a very excellent talk. The Johnson 2000 study you referenced showed that methadone was more effective at keeping patients on treatment for longer than buprenorphine. Why do you think this is, and what are ways providers can help extend the buprenorphine treatment duration?
Another outstanding question with a complicated answer. I think that we need additional trials and studies to determine ways, particularly in office-based settings, that we can improve treatment retention on buprenorphine. Currently, there's not a lot out there beyond what I just described. I think one of the reasons, we've all puzzled over this result from the START study also, which demonstrated the same thing. And I should emphasize that study by Johnson was not a statistically significant difference, but subsequent studies have been, including the START study. One potential explanation is that these patients in the START study were all recruited from opiate treatment programs where people were coming in who all pretty much had very severe opioid use disorder. They were still trying to use on methadone. So and use is not successful. It takes a lot longer period of time to block the euphoric effects of heroin. On methadone, you have to get to a fairly high dose for that to happen. Whereas buprenorphine, you start to see that in the first few days at a relatively modest dose. And so for patients that are ambivalent about recovery, sometimes they'll very quickly fall off of buprenorphine in that setting. But I know that's not a very satisfying answer. And we need a lot more research in this area.
Okay, so would any of these medications for opioid use disorder interfere with any psychiatric medications, or are they generally safe to take together?
No, they're quite safe to take together with buprenorphine. Mm-hmm. There are some drug-drug interactions between methadone and certain medications that inhibit the P450-3A4 pathway, and I look up those medications before I prescribe them, look up for those drug-drug interactions. The antidepressants are typically quite safe, and many of the other medications for bipolar disorder and schizophrenia, but I will always look up drug interactions before prescribing.
Mm-hmm. Okay. So have there been any studies that you're aware of analyzing the characteristics of people who are able to quit cold turkey? And is there something different from those who consistently relapse?
That's another great question. And there's not a lot of data that I'm aware of about this. The proportion of people who can quit cold turkey and completely abstain from opioids for years on end, like the famous example of Ray Charles, it's diminishingly small. They tend to be people with a lot who perceive themselves to have a lot to lose, and I never recommend somebody quote unquote going cold turkey. Even if somebody chooses not to continue on agonist therapy or try agonist therapy, I will recommend extended release naltrexone for that patient as a sort of a safety belt for relapse in those first several months.
Mm-hmm. Sort of related to that question, as you use the word relapse there, someone's asking if it might be helpful to use a term other than the term relapse, as we are often addressing folks who have yet to meet remission criteria.
Oh, what a wonderful comment, and you're exactly right. I still use the term relapse as kind of shorthand, but I think we use a lot of language in addiction treatment that that's a holdover from a time that didn't maybe necessarily appreciate the medical complexity of substance use disorders. The more we can use more patient-friendly, patient-centered terms, the better. So a better way, instead of talking about relapse, would be just talk about resumption of use.
Interesting. Okay.
Thank you for bringing that up. Whoever brought that up.
That's a great question. Yeah. Okay, next, do you have any thoughts about the optimal recovery supports in the community for this population? For example, have you found peers to be an important component, and if so, when?
Oh my goodness! If you have peers available in your community, just harness to that train and go with it. There's a fair amount of data around the use of peer recovery support specialists in specialty treatment settings, and a meta-analysis that shows they're generally quite effective for improving treatment outcomes. It's less well studied in other settings like office-based primary care treatment or rural settings. that just have fewer resources. But if you have access to that, that would be fantastic. We need more studies of the use of peers in office-based opioid treatment. We need more studies of the use of peers in rural treatment settings as well. Right now, I'm currently working with peers in 2 settings. We have an inpatient addiction medicine consult service at OHSU, and the peers are really the linchpin of that service, who do just so much direct patient interaction, conflict de-escalation, readiness for change interventions. They're absolutely crucial. And then as we get people started on medications, they're very successful in these things that may sound small and not a part of medical practice, but are absolutely crucial. Things like helping patients with transportation, setting up visitation with their children if that's an issue, helping them navigate the court system. These are essential aspects of recovery, and the peers are quite effective for that. We also have one study that's currently evaluating the use of peers for engaging people completely outside of care in rural areas with opioid use disorder. And anecdotally, we've had about 20% success engaging those through use of peers, those people.
Okay, so we have 2 questions about pregnant women and buprenorphine. The first one is, what is the best practice for tapering pregnant women off from buprenorphine, and can they switch directly to methadone? And the second one is, what does medication management for neonates exposed to buprenorphine look like?
Sure. I'll preface this by saying I do not take care of these patients. We have a service here that does. The mother trial demonstrated that buprenorphine was effective in both treating patients with opioid use disorder throughout their pregnancy, as effective as methadone, and also led to fewer days of neonatal abstinence syndrome for the baby afterward. And so buprenorphine has really become one of the standards of care for treatment of opioid use disorder during pregnancy. We do use the mono product, the buprenorphine without naloxone, for that due to animal studies that demonstrate increased risk with naloxone. That being said, there was a recent study last year that showed no adverse effects of people maintained on buprenorphine naloxone during pregnancy. Methadone is still certainly a valuable option. If somebody is stable on buprenorphine and they become pregnant, they should switch to the mono product, but not be required to switch to methadone. If they're stable on methadone, they should continue on methadone, typically. And then I would have a conversation about their recovery when it's most important, and that's after that baby's born, and continuing them on buprenorphine combination product with naloxone afterward.
Mm-hmm. Is it possible to use buprenorphine without naloxone? Yes,
it's definitely possible. The buprenorphine monoproduct has a slightly increased risk of diversion and misuse compared with the combination product, and that's why most people recommend always starting with the combination product. Times when the monoproduct, buprenorphine alone, is indicated is, as I said, during pregnancy, and also if you're working in a very controlled environment. For example, an opiate treatment program where you're doing daily dispensing and directly observed therapy, you know, there's no advantage to the combination product, and it's less expensive.
Mm-hmm. Okay, let's see.
Just as a clinical pearl, I've found that when people come in and say they only respond to the mono product and that's the only thing they want, that's usually a bad sign.
Hmm. Is there a reason to start with oral buprenorphine instead of going straight to the monthly injection after induction? Is there a benefit to the oral versus the monthly injection?
Oh, wow, another great question. So this is an evolving response. Right now, the best answer is to start with the sublingual buprenorphine, because that's what most Medicaid programs are most likely to cover. I'm not aware of any Medicaid programs so far, unless they've been approved in this last week, that currently cover the only available injectable buprenorphine on the market right now. That product, so just from a practical standpoint, I think it's going to be a long time before most of our patients have access through their insurance to extended release buprenorphine. The second point is that the FDA approval for the currently approved extended release buprenorphine product made by Indivior, it was approved with a lead-in period of sublingual buprenorphine. So all of the trials that led to its approval required initiation of sublingual buprenorphine first and then transition to the injection. The product that's likely to be approved any day now, it's a slightly different design from Braeburn, doesn't have that requirement and is going to be more likely to be able to inject immediately.
Mm-hmm. Okay. Whoops, I think I just hit some slides there. Sorry, everyone. Okay, if a patient detoxes using buprenorphine and doesn't continue with maintenance therapy after that, will they experience buprenorphine withdrawal? And if so, how severe will that be? Yes,
buprenorphine is an opioid and has a withdrawal syndrome just like any other opioid. I've found that people can usually get down to 4 milligrams, even 2 milligrams without much of a problem at all, but that they can develop substantial withdrawal symptoms going from 2 milligrams to 0. And because of its longer functional half-life at the opioid mu receptor, this can last for days. And so I treat aggressively with supportive medications like clonidine or tizanidine, antiemetics potentially, and non-opioid analgesics and non-controlled substances for sleep aids.
Mm-hmm. Okay, it looks like our last question is, so if you're comparing methadone to Suboxone, you're going either direction maybe, how do you know what doses are equal to each other? For example, what is 8/2 milligrams of Suboxone equal to in dose for methadone?
It's tough to compare. They're a little bit apples and oranges because buprenorphine is a partial opioid agonist instead of a full agonist. You'll never find it in those dose conversion tables where even methadone is difficult to interpret. So I can tell you my anecdotal perspective. Anecdotally, if somebody is on a robust dose of methadone maintenance of, say, 120, 140 milligrams, they're going to require 24 milligrams most likely eventually of the buprenorphine. But I certainly would never attempt a direct conversion. You want to start just like you would with anyone else after tapering off the methadone by starting with 2 to 4 milligrams, and figuring out what dose they feel good at.
Mhm. Okay, great. I think that was our last question. Just want to remind everyone, since a few people asked about this as well, we will have the slides and the recording of this available on the NWATTC website, and I'll send an email out to everyone later today with a link to that. And the recording includes this Q&A session, so these questions and answers will be captured in that. Okay, thank you so much, Dr. Korthuis. That was really wonderful.
Well, thank you so much, everybody, for joining and for your interest in this important subject.
We're getting a million comments of everyone saying thank you. That was amazing. So great job. All right, have a great day, everyone. Bye-bye.
Bye.